A very good morning to one and all. So today's topic of discussion will be on tooth discoloration and its management. Management will be dealing with mostly regarding bleaching. Mostly comes as a short note answer for your final year exams. I'll be covering the topics under the following headings. That will be introduction, then there will be the classification, then how to go about with the treatment, the effects, and as well as the novel management techniques, conclusion, and references. So moving on to the introduction, tooth discoloration is one of the most commonly reported complaints, which is seen in patients seeking aesthetic treatment. Variation in tooth color can be influenced by intrinsic and extrinsic factors ranging from chemical ingestion to consumption of food that can cause staining. Currently, as we are all aware, there are several products on the market that remove stains and claim to whiten teeth. There are several options for the patients which range from simple professional prophylaxis and the application of bleaching gels to whiten teeth for home use or supervised in a dental office. So bleaching gels normally consist of different concentration of hydrogen peroxide or carbamide peroxide and involve various forms of application. Tooth color varies between the incisal edge and the neck of the tooth from one group of teeth to the next and from one person to person. As we have all noticed, the enamel as such does not have any particular color and it's mostly translucent, whereas dentine is the one which always represents a shade of the tooth. It's more slightly yellowish in color in compared to enamel, and the dentine itself they are more prone to staining if exposed alone. Cementum as well is more yellow in color, and the pulp is always seen through the teeth as a reddish or a pinkish hue. So, like I mentioned, that various studies have shown that dentine is the one which plays a major role in the final shade of the tooth. And experimental evidence have also led enamel has a certain degree of translucency and no intrinsic color as such. It does not have a color of its own, but it's mostly what is seen through the dentine. So according to Engel, a tooth discoloration is defined as any change in the hue, the color, or translucency of a tooth due to any cause. It could be because of a restorative filling material, it could be of drugs, pulpal necrosis, or hemorrhage. Moving on to the classification of tooth discoloration. Tooth discoloration can be classified into extrinsic and intrinsic, whereas it can be a combination of both extrinsic and intrinsic factors. Moving on to the mechanism of tooth discoloration, like I mentioned, it could be because of extrinsic, which means it's primarily because of external factors, and there are intrinsic stains, which means it could be because of the internal factors from within the tooth system, which means it could be more of a developmental disorder, that is during the tooth germ formation. So in extrinsic, it could be primarily because of chromogenic bacteria. It's most commonly seen by direct staining of food, especially when you have excess of tea, coffee, even turmeric. All this can lead to a direct staining by food. Then chemical transformation of the pellicle, that is from the tannic acid, glycoprotein, and furfural. Then in case of intrinsic stains, there are disturbance in the tooth germ formation, like I mentioned. Genetic disorders include porphyrin pigments, which has a higher affinity for calcium phosphate. So they tend to deposit on the tooth within the tooth within as in the inside of the tooth surface, which is commonly seen or represented as an intrinsic stain. It could be because of any metabolic disorders such as deposition of bilirubin in the developing enamel and dentine. Then it could be primarily because of any medication, that is tetracycline stains that are seen. Then fluorosis, that is excessive intake of fluoride during early maturation stage of enamel formation. So if you look at an extrinsic stain, if the tooth surface that is on the enamel, there's a pigment deposition which can be caused mainly due to, like I mentioned, could be coffee, black tea, green tea, etc. A chemical reaction occurs which results in the formation of a colored protein which accumulates over a period of time, and that causes the dullness of the tooth or a change in color. Whereas in the case of dental fluorosis, you can see that is when the tooth, when during the growing ages, when the body is exposed to a higher number of fluoride ion, there is an increased deposition of fluor hydroxyapatite, that which will degenerate the amyloblast, and then secretion of serine protease enzymes, and there's an altered enamel mineralization or dental fluor, which causes dental fluorosis. Like for example, if there is a brown stain which is thin and bacteria, it's mostly thin and bacteria free. It's commonly seen on the buccal surface of maxillary molars and the lingual surface of mandible incisors, and the least on the labial surface of maxillary anterior teeth. Whereas the etiology could be found in individuals with poor oral hygiene due to deposition of tannin, which is found in tea, coffee, and other beverages, and those who use a dentifrice with inadequate cleaning and polishing action. Whereas in case of a green stain, these are tenacious and thick stains which is common in children. They are found on the facial surface of the maxillary anterior teeth, which is near the gingival third, and it's considered to be the remnants of the primary enamel cuticle that has been stained. Discoloration is considered to be due to fluorescent bacteria and fungi like penicillin and aspergillus. It has been seen in people exposed to copper salts in mouthwashes. So there are various colors, like I mentioned in this table: brown stain, black stain, and green stain, and orange stain is primarily included just for your knowledge. Metallic stains are also seen. Then yellow colored stains, red, black, and violet black stains are also seen. There are various reasons why these are also seen. For example, in case of the metallic stain, is mostly seen staining that has occurred because of there's an exposed tooth surface to the outer environment. And the most common etiology is that the metals combine with the acquired pellicle to produce a surface stain or penetrate the tooth substance to cause permanent discoloration. And different metal produce a different color of staining. Extrinsic stains, which is most primarily seen in all of us. So that can be divided into daily acquired stains and also because of chemically acquired stains or because of chemicals that we tend to use in our day-to-day lives. So daily acquired stains is that all of us, if scaling is not done every 6 months in a year, there is a tendency for plaque accumulation, which over in time leads to calculus deposition, and that can lead to discoloration of the tooth. Then food and beverages to add on to it. In case of tobacco users, and if the oral hygiene is poor, then swimmer's calculus, fluorexidine. Gingival hemorrhage also can cause a daily acquired stain. Whereas in chemicals, chlorhexidine mouthwashes, that is frequent uses or prolonged uses of chlorhexidine mouthwashes can also lead to chemical stains. Chemical stains studies have been reported where people working in iron factories, there is tendency for black stains. Then green stains are commonly seen because of mouth rinses which used to contain copper salt. Then yellowish brown staining is commonly seen in cases where stannous fluoride mouthwashes have been used. And tooth staining increases with the use of chlorhexidine, like I mentioned. That primarily happens because of the takes place in the acquired pellicle, and there's condensation and polymerization of proteins and carbohydrates and discoloration of the acquired pellicle. Chlorhexidine could bind to the dietary chromogens to surface producing stains. The famous classification given by Nathu, that is Nathu's classification of extrinsic dental stains, which is the N1, that is dental stain or direct, that is N1, N2, and N3. N1 is a colored material which binds to the tooth surface to cause discoloration, and the color of the chromogen is same as that of the dental stain. N2 is basically the colored material changes color after binding to the tooth. And these N2 stains they get darker with age. Whereas N3 stains are basically colorless free chromogen binds to the tooth surface and undergoes a chemical change to form a chromogenic material, which includes basically chlorhexidine, stannous fluoride, carbohydrate-rich food such as apples and potatoes. Intrinsic causes of tooth discoloration basically occurs from the incorporation of pigmented materials into the dental tissue. They are classified into pre-eruptive causes and post-eruptive causes. Pre-eruptive could be because of disease or medication. Intrinsic causes or the intrinsic stains, like I mentioned, it could be prenatal, postnatal. That comes from under environmental, and sometimes it could be hereditary, which includes again the tooth only, or it could be accompanied by a systemic disorder. So in case of prenatal, which is seen in the environment, an example would be to give is a maternal infection, whereas in case of postnatal, it could be because of infection which is caused because of measles or chickenpox or scarlet fever. And in case of hereditary, amelogenesis imperfecta, and if there is a presence of a systemic disorder, then epidermolysis bullosa. Pre-eruptive, the pre-eruptive causes, it could be alkaptonuria, it could be because of erythroblastosis fetalis, amelogenesis imperfecta, fluorosis, dentinogenesis imperfecta, and erythropoietic porphyria, as well as in case of tetracyclines. Post-eruptive causes could be pulpal changes, trauma, dentine hypercalcification, obviously in case of dentinal caries, then restorative materials and the operative procedures, then aging, functional and parafunctional changes. In case of Ingalls classification of tooth discoloration, it can be patient-related cause or a dentist-related cause. A patient-related cause can include primarily pulp necrosis, intrapulpal hemorrhage, calcific metamorphosis, age-related, enamel hypoplasia, fluorosis, amelogenesis imperfecta, and dentinogenesis imperfecta. Then tetracyclines. Dentist-related cause is basically pulp tissue remnants, intracanal medicaments, obturation materials, amalgam, pins and post, then resin composites. Now, when we move on to the management of a tooth discoloration or the treatment modalities include, firstly, you need to diagnose a tooth discoloration. In diagnosis, we deal with basically the dental history, the medical history, Then you ask on with the family history, the personal history, social history, which means if there's any habit history. Intraoral examination, scratch test. Scratch test is primarily done to differentiate between external and internal staining. External staining, when a scratch test is performed, it can be removed, whereas in case of internal staining, it may not be removed that easily. It cannot be removed. Then radiographic examination and the vitality test. So when a patient visits the dentist, what you need to keep in mind is probably in the first visit would be to determine the amount of calculus, stains, plaque habits, and the attitude of the patient. And in your second visit, you would want to review all your radiographs, review of medical and dental history, preliminary treatment plan needs to be explained to the patient. In case of your third visit, you can actually propose a treatment plan that is a composite resin applied on the tooth, then the Vita shade guide, then the wax study model, a computer imaging, and then the final treatment plan. We can even follow the aesthetic evaluation chart as mentioned in the slide. And in case of management of extrinsic strain, you need a thorough dental and medical history. Should be examined, the teeth should be examined for position and distribution of stain, enamel roughness and defects, caries or defective restoration, and plaque and calculus deposition. Information of intake of drugs and oral therapeutic agents. Workers exposed to industrial chemicals should always wear a mask. Many extrinsic stains can be removed by toothbrushing, professional prophylaxis, air jet polishing. In case of roughened enamel surfaces, fine polishing paste and superfine aluminum oxide polishing discs can be used, whereas application of pumice and water slurry for 30 seconds with rotating rubber cup can also be used. In case of extrinsic tooth stain, which can be caused, like earlier mentioned, diet, tobacco, oral therapeutics, or poor oral hygiene, it can be removed by various methods by use of peroxides, abrasives, that is aluminum oxide, calcium carbonate, silica, then chemical agents which include sodium pyrophosphate, sodium tripolyphosphate, sodium hexametaphosphate. Based on their ability to displace anions, negatively charged macromolecules, and acquire enamel pellicle from tooth surface. Sodium hexametaphosphate, it whitens by the extrinsic stain removal, helps prevent the stains from forming or happening, and inhibits the calculus formation. Enamel microabrasion, which is one of the most common methods used in case of removal of small amount of enamel surfaces, which is in case of superficial irregularities and certain intrinsic stains. Enamel microabrasion can cause superficial demineralization. It modifies the optical properties of enamel, no longer reflects or refracts light, thus hiding the underlying stains. The two main techniques used for enamel microabrasion are hydrochloric acid or the pumice method, or by the use of phosphoric acid and the pumice technique. So what happens is that abrasion of enamel prisms plus enamel erosion by use of a hydrochloric acid or phosphoric acid, it results in the formation of compacted prism-free enamel surface with altered optical properties. In this diagram, you can see the superficial enamel discolorations that can be seen. Microabrasion technique is followed. That is in figure B. You can see that they are using a fine polishing burr to remove the enamel irregularities, following which, with the help of phosphoric acid and pumice and using a rubber cup, it removes the enamel irregularity that is present. You can see in this image that using the microabrasion technique, the enamel discoloration defects can be removed. How much enamel layer is removed? The amount of enamel removed by microabrasion depends on the number of applications of the concentrated hydrochloric acid and the pumice. Example, 1 to 10 application of the mixture for 5 seconds each will remove about 12 to 46 micrometer respectively. 3 and 15 application for 5 seconds for 5 seconds each removes 25 and 140 micrometers, whereas 12 applications for 30 seconds removes 22 micrometers. Microabrasion teeth can develop a darker shade or yellowish coloration after treatment because the remaining enamel surface is slightly thinner and translucent and the dentine appears more evident. So microabrasion should be done in a way to remove as minimal as enamel as possible. Greater removal of enamel causes more of the dentine to be seen, and in the long run the dentine tends to take up stains on a higher rate than enamel. Hydrochloric acid and pumice microabrasion, the methodology. So what we have to do is we need to clean the teeth with pumice water, wash and dry. Isolation, which is followed by application of the rubber dam. What we need to do is we need to mix 18% of hydrochloric acid with pumice, which will form a slurry. Apply a small amount on the labial surface for 5 seconds. Wash for 5 seconds. Apply fluoride drops for 3 minutes. Remove the isolation and polish the teeth. You need to polish the teeth with fluoridated toothpaste just to avoid sensitivity. Review in 6 months to check the pulp. And phosphoric acid and pumice microabrasion, the technique is more or less the same. What we need to do is that apply 35% phosphoric acid for 30 seconds, wash and dry, remove the frosted enamel with a finishing burr till a shiny enamel surface appears, clean the teeth with pumice and water slurry. Moving on to the bleaching techniques. Home bleaching technique, night guard bleaching or matrix bleaching. Proved to be successful with 9 out of 10 patients experiencing a lightening of their teeth in 2 to 6 weeks after application in a study which was conducted by Haywood et al. In 1993. For rapid and effective result, in-office bleaching combined with matrix bleaching sessions, that is the power matrix bleaching. The advantages of home bleaching technique is that it's a very simple method, it requires less chairside time and it's cost effective. The disadvantages is that patient compliance is mandatory. Effect, that is the amount of time the tray is worn, then chances of abuse, which means some patients might tend to use more of it for more whiter teeth. Indications are in case of mild generalized staining, superficial staining, age-related discoloration. Contraindications include insufficient enamel, deep surface cracks, severe fluorosis and hypersensitivity. How to proceed with a bleaching technique is that you need to take photographs for comparison, which means you need a before photograph as well as during the treatment as well as the after phase treatment. You need to make an alternate impression of the arch to form the vacuum formed matrix. According to Haywood, the best material to form the matrix, that is 0.035 inch clear soft tray, that is the ultra dent, is made. A patient try-in is done. Instruct the patient to place a drop of the bleaching solution around each tooth area. Tetracycline stains take about 1 to 4 hours daily for about 4 to 6 weeks. Common is 1 to 3 hour daily with one application or changing solution once a day. The solutions commonly used are 10 to 15% carbamide peroxide, more viscous than 5% solution. Adequate patient monitoring required in such treatment procedures. Allow for touch-ups and retreatment as necessary. New solution can be given when required, and according to Haywood, it may be 3 years before retreatment is needed. Like we mentioned, you need to take an alginate impression to form a tray which will hold the bleaching material. Selective bleaching can also be achieved by matrix bleaching by removing the specific areas in the matrix that is used. Management of intrinsic stain. Intrinsic stains occur within the enamel or dentin, therefore more difficult to treat. It can affect vital or non-vital teeth as well as endodontically treated tooth. Major advances on bleaching agents and new techniques to enhance the diffusion of these agents. In these diagrams, you can appreciate the surface enamel stains which are removed using microabrasion in the first figure, whereas the deep internal stains were removed using the bleaching techniques. The effectiveness of two commercial microabrasion products were compared, and it was found that microabrasion technique can be used in the management of mild dental fluorosis as well. McKean's microabrasion technique. McKean's in 1996 is a technique that involved combination of hydrochloric acid and hydrogen peroxide to remove fluorosis stains, bleaching, and chemical abrasion. So McKean's solution consists of 5 parts of 30% hydrogen peroxide, 5 parts of 18% hydrochloric acid, and 1 part of ethyl ether. Disadvantages is that solution applied could flow to the unaffected enamel. Working solution needs to be freshly prepared. Decreases micro hardness of enamel, and application of GC tooth mousse increases the micro hardness as well. The mechanism of action of McKean solution: ethyl ether, which removes the surface debris. Hydrochloric acid etches the enamel. Hydrogen peroxide bleaches the enamel. But various studies have shown that a modification by replacing the hydrochloric acid by 20% sodium hydroxide is as effective as the McKean solution with lesser calcium dissolution, which means lesser enamel is altered. McCloskey, that is a simple method of elimination of fluorosis stains in which 18% hydrochloric acid is used. So the acid is applied with cotton wrapped over the end of a serrated instrument. Stained areas are rubbed with a slight erasing motion. Application of acid and pumice slurry on labial surface with a rubber prophylaxis cup. Removal of superficial enamel stains include enamel macroabrasion, etching and microcutting, combination of enamel macroabrasion and microabrasion. Removal of deep intrinsic enamel stains and considerable loss of enamel integrity. In case microabrasion or macroabrasion or bleaching treatment doesn't work, you need to think of other treatment options such as masking it with using a composite or porcelain. The bleaching techniques. Bleaching techniques involves an oxidative chemical that alters the light absorbing nature of a material structure, increasing its perception of whiteness. So initially chloride, sodium hypochlorite, sodium perborate and hydrogen peroxide were used. As the years went by, 1961, the walking bleach technique, that is sodium perborate, was replaced with hydrogen peroxide, which is the night guard or vital bleaching. And as the years passed by, lasers were introduced. The mode of action of all whitening agent is by an oxidative principle. Whitening agents that can be used were hydrogen peroxide, carbamide peroxide, sodium perborate, and chlorine dioxide. The mode of action or the mechanism of action is more or less the same in these diagrammatic representation. It basically is an oxidative reaction which breaks down the high molecular weight compounds or splits it into a lower weight molecular compounds. Classification of the bleaching techniques include vital, non-vital, and the laser-assisted bleaching. Vital includes at-home bleaching or in-office bleaching. In-office bleaching include microabrasion, non-thermocatalytic, and thermocatalytic bleaching. Non-vital bleaching includes the walking or the intracoronal bleaching technique, the thermocatalytic in-office bleach, inside and outside bleaching, closed chamber bleaching or the extracoronal bleaching, then the carbon dioxide laser and the argon laser. Constituents of the bleaching gels mostly consist of carbamide peroxide, consist of the hydrogen peroxide and sodium hydroxide, sodium perborate, thickening agents, urea, surfactant and pigment dispersants, preservatives, vehicles, glycerin and dentifrice, flavors, fluoride and 3% potassium nitrate. The vital tooth bleaching, the indications of vital tooth bleaching are moderate tooth discoloration, or which can be caused due to genetic disorders, fluorosis staining, post-traumatic discoloration. Contraindications include pronounced tooth stains, presence of cervical lesion, young patients, smoking or hypersensitivity. In-office vital tooth bleaching or the power bleaching. How the process is done is by the following steps. So what we need to do in case of in-office or vital tooth bleaching or the power bleaching is that we need to protect the gingiva with Vaseline or any oral base, and then you need to isolate the tooth with rubber dam. Clean with slurry of pumice and water, wash and dry. Gauze soaked with 30 to 35% hydrogen peroxide should be placed on the teeth, and the bleaching light should be positioned for up to 30 minutes with the heating unit placed 2 minutes per tooth. Rubber dam should be removed and area should be rinsed with hot water. The conventional bleaching light can be used, tungsten halogen curing light can be used, xenon plasma arc light can also be used, argon CO2 and diode laser light can also be used to enhance the effectivity of tooth bleaching. Heatless systems for young patients who experience post-operative sensitivity are also available. That is the Highlight ACAL Plus, which includes hydrogen peroxide plus sodium perborate, and the commonly used solution for non-thermocatalytic bleaching can also be used, which includes superoxide, that is 5 parts of hydrogen peroxide and 1 part ether. The McKean solution and modified McKean solution can also be used. According to some authors, the light from a traditional halogen lamp or an operating lamp placed in close proximity to the tooth surface accelerates the breakdown process and improves the bleaching reaction. The argon laser or heat produced by carbon dioxide laser can also be used. Main concern in terms of safety and efficacy when using laser energy for bleaching purpose. As mentioned in the diagram, you can see. Basically, an external mode of energy such as heat or light increases the efficacy of the bleaching agents. Current chairside techniques, that is the compression methods in conjunction with viscous gels, which includes 35% hydrogen peroxide bleaching gel, that is the opalescent extra, placed in a delivery tray where it is compressed and activated for 10 to 15 minutes. This encourages the oxygen ions to migrate towards the inside of the enamel. Also 35% hydrogen peroxide combined with calcium fluoride and titanium dioxide. These are the different bleaching agents that are available in the market. the product designation as well as the composition. Non-vital tooth bleaching. Indications include discoloration due to loss of pulp vitality and pulpal hemorrhage. Contraindications include children and young adolescents which has undergone periodontal treatment, trauma, external or internal. The method of thermocatalytic tooth bleaching is that the isolated tooth isolate the tooth that needs to be bleached, which means placement of a rubber dam. Place the bleaching agent, which can be superoxide and sodium perborate, separately or in combination in the pulp chamber. Heat the bleaching solution using the bleaching wand or the light curing unit. Repeat procedure till the desired tooth color is achieved. Wash tooth with water and seal with dry cotton and temporary restoration. Recall after 1 to 3 weeks and restore with composite after. So in this you can appreciate that in case of this is a RCT treated tooth in which first a barrier is placed. The barrier is basically a GIC barrier, following which superoxide is used. Superoxide is primarily used in case of for the whitening of the tooth along with the heat transmitting instruments such as the bleaching wand. The precautions that need to be taken are: a good isolation technique should be followed, adequate endodontic obturation, avoid acid etching and avoid strong oxidizers, avoid heat and recall periodically. Avoid heat as in avoid overheating. A controlled heat, otherwise it can cause damage to the periodontal ligaments. Modified walking bleach technique, internal or external bleaching. Here, what we need to remember is that the first 3 steps, that is isolate the tooth, preparing the access cavity by removing 2 to 3 millimeters of gutta percha below the CEJ, placing a mechanical barrier, cleaning the access cavity, small pellets of cotton placed for seal. Check fitting of bleaching tray and advise patient to remove the pellet before the bleaching. Instructions for home bleaching is given, and after bleaching, the tooth is irrigated and cotton pellet is placed. Reassessment of shade after 4 to 7 days when desired color is achieved, and there is a seal with temporary, and after which 2 weeks later there is a permanent composite restoration. The difference here is that a bleaching tray is given to the patient, in which when the patient, once he returns back to his house, he can remove the pellet, add some more bleaching agent to the tray. It enhances the bleaching. Or even if that is not required, the bleaching agent is placed within the access cavity and the patient is recalled for follow-up appointments, as mentioned here. So here you can see that there is the gutta percha, there is the barrier, the cotton pellet with the bleaching agent or the bleaching gel, and a well-fitted bleaching tray is placed over it along with the bleaching gel. Advantages is that it's a more surface area for the bleaching agent to penetrate. There's a lesser treatment time, less incidence of cervical resorption, lower incidence of carbamide peroxide. Disadvantages is that if it's a non-compliant patient, then it's difficult. There are chances of over bleaching as well. Closed chamber bleaching or the extracoronal bleaching is existing restoration not removed, and the bleaching paste is applied via the bleaching tray. In case of totally calcified canals, when bleaching maintenance is required and when a single dark non-vital tooth is present. Veneers and full coverage crown. Veneers commonly used in the case of management of tooth discoloration. In case of veneer preparation margin, there should be placed slightly subgingivally to mask the difference in the tooth color. Zirconia crowns can be also useful in the treatment of stained teeth caused due to tetracycline. Zirconia crowns are non-translucent, which means they do not allow light to pass through. So in heavily discolored tooth, you can consider going in for options of zirconia crown. Whereas PFM crown gives adequate strength and required parafunctional habit, which can be combined with deep tooth discoloration. Here you can make out where occurrence and management of dental fluorosis were masked by use of veneers. You can see the veneer preparation, which is more or less liquid gingival, and in figure B you can make out after the cementation. The most common effects of bleaching agent is tooth hypersensitivity, as it alters the enamel layer, making the enamel layer more porous. There is a very high chances of tooth hypersensitivity. Bleached tooth or the bleach or cases which are advocated for bleaching have a greater risk of cervical resorption. Some studies state that the mixture of sodium perborate with hydrogen peroxide presents excellent aesthetic results and cause root external cervical resorption. One undesirable consequence of intracoronal bleaching is the use of excessive hydrogen peroxide diffusing into the periradicular tissue, possibly through cement defects. Reduction of hardness of enamel. It causes uniform change in color through the dentine. Then effects on pulp can also result in tooth sensitivity. Effects on pulp is that there is a transient reduction in the pulpal blood flow and occlusion of pulpal blood vessel. External root resorption in case of 30 to 35% of hydrogen peroxide when used as intracoronal bleaching. Effect on the restorative materials include composite amalgam and GIC, where it might deplete the bonding strength. It can cause mucosal irritation and toxicity. The reduction, the proper timing for placing a bonding a composite restoration to bleached enamel is something we must always look at. The reduction in the bond strength is important since the presence of oxygen released by bleaching processes inhibit polymerization of the adhesive system and is responsible for compromising the bond strength between restorative material and dental substrates. From the studies conducted, it was confirmed that immediate bonding should be avoided after bleaching, and the type of adhesive system used in bonding should be either acetone based or water based. Majority affects the values of micro shear bond strength, and the acetone based adhesive system showed a better wet bonding strength than the water based. The novel management techniques, that is development of power jet deposition technique and new treatment for discolored teeth. The possibility of using the creation of titanium oxide hydroxyapatite layers with the new power jet deposition technique as a new treatment for discolored teeth was assessed. Hydroxyapatite layers formed with a new handpiece type, that is the powder jet deposition technique device, demonstrated excellent material properties in vitro. According to studies carried out to determine the influence of titanium particles in a concentration of 0.10 to 0.25%, the particles induced a whiter tooth color and simulated the opalescence of human enamel. It was confirmed that titanium oxide or the hydroxyapatite layers could whiten the tooth surface and showed higher color stability or the management of tooth discoloration. Conclusion is that tooth discoloration is a multifactorial etiology. Obligation of oral healthcare practitioners to educate the public on true economic value and safety of prescribed whitening treatments. It's a combined treatment of bleaching and aesthetic restoration is always considered, because bleaching alone itself cannot treat the underlying discoloration. Sometimes we need to go in for aesthetic restorations to mask the discoloration which is present on the teeth surface. Aesthetic restorations such as porcelain laminate veneers, PFM crowns, or zirconia base crowns. Okay. These are the references. Thank you. Have a great day. Thank you.